Hello, I'm Joseph Plasic. I'm currently a postdoctoral research fellow at Brigham and Women's Hospital in the M-Terms lab. I'm a health data scientist, clinical informaticist, and dynamic systems theorist by training with a background in computer science, natural language processing, and machine learning. Today, I want to look at an example illustrating the importance of interdisciplinary collaboration in informatics and data science related to adverse drug events. Today's talk is designed to be at an introductory level. As a disclosure, this project identifying adverse drug events in ambulatory primary care notes is a collaboration between Brigham and Women's Hospital and IBM with financial support from IBM. IBM partners with academic leaders to advance the science of artificial intelligence. In today's talk, I will be discussing the annotation process and sampling plan development of an ongoing study on the prevalence of adverse drug events. The short version of this talk: adverse drug events are described as unintended and harmful effects resulting from medication use and are associated with suboptimal patient outcomes and increased health services utilization. They may or may not result from an error and are classified as non-preventable, preventable, and ameliorable ADEs. Natural language processing models often require a large collection of documents for training purposes. Annotating a random sample of notes for something that has low prevalence, in other words, it's relatively rare, will result in a biased or imbalanced dataset, which needs to be accounted for somehow when training using machine learning methods. Ideally, the dataset would be balanced, such as a 50-50 split between cases and controls. In curating a cohort, our goal then is to create an annotated dataset that is both balanced and diverse, so it's representative of both common and rare adverse drug events. Conducting a sampling study prior to annotation can help us envision a path to make this goal a reality. In this way, we can upsample notes that are more likely to contain ADEs in order to optimize the efforts of our clinical annotation team. There are several tasks in particular where clinician input is desirable, such as cohort identification, as these are areas where clinical expertise and knowledge of workflow is essential. Supervised methods of machine learning require annotated data, and to get high-quality annotations, we need annotators who are experts, in particular clinical subject area that we are annotating for. Clinicians are on the front line of patient care and know what's really going on in the patient care environment. They're essential to ensure quality in the clinical natural language processing systems that we create. Here are several examples of adverse drug events, such as analgesic overuse headache, drug-induced hypotension, anaphylactic shock due to an adverse drug event, etc. Adverse drug events are important in the context of patient safety. In 2000, the Institutions of Medicine put out a report called To Err is Human, which highlighted the high prevalence of preventable medical errors in current practice and helped to shift care to be more team-based and patient-centered. Care increasingly has focused on prevention, which tends to be conducted in the outpatient or ambulatory setting. The widespread use of electronic health record systems in care settings has made it easier to identify potential errors, such as adverse drug events. Medical errors rank among the top causes of death. As a growing health concern, accurately identifying adverse drug events can lead to improvements in patient safety and quality of care. Still, it is unclear whether challenges in technology, delivery and management, and payment models have led to overall improvements in patient safety and quality of care. Prior research in this area has suggested that notes from clinical encounters with certain international classification of disease, ICD-10 billing codes, are likely to contain ADEs. We found that a systematic review of Hole by Hole et al. Contained the most comprehensive list of terms at a high level of granularity. ICD-10 is a hierarchical terminology, and so we compared this to a list at our institution and found that some of the more specific lower level terms in the hierarchy should also be included, because this is how they are stored in our EHR. One study found that 6.5% of all hospitalized patients experience an ADE. However, compared with events occurring in the inpatient setting, much less is known about ADEs in the outpatient setting. Substantial variability exists in the methods used to detect and identify these events. The exact prevalence of adverse drug events in the outpatient setting is unknown, with annual estimates ranging from 5 to 35%. Electronic health records and computational methods to analyze them, such as natural language processing, have been used to improve reliability of identifying adverse drug events. Brigham Health, a global leader in creating a healthier world, consists of Brigham and Women's Hospital, Brigham and Women's Faulkner Hospital, and the Brigham and Women's Physicians Organization, as well as many related facilities and programs. With more than 1,000 inpatient beds, approximately 60,000 inpatient stays, and 1.7 million outpatient encounters annually, Brigham Health's 1,200 physicians provide expert care in virtually every medical and surgical subspecialty in 2 patients located locally in Boston, regionally in New England, and around the world. Brigham and Women's Hospital is a teaching affiliate of Harvard Medical School and a founding member of Mass General Brigham, a large integrated healthcare network. US News and World Report consistently ranks Brigham and Women's Hospital among the nation's top 10 hospitals. Good science is collaborative in nature and has rigorous and reproducible methods that minimize biases. We manage conflicts of interest with transparency and disclosure, but not categorical exclusion through our industry academic collaboration. For our part of the collaboration, Brigham and Women's Hospital has the clinical data, expertise to interpret that data, and a multidisciplinary team of clinicians and data scientists focused on this task. The overall project objective is to train and evaluate the ability of IBM's Annotator for Clinical Data product to identify ADEs, specifically for outpatient primary care notes. After curating the corpus of notes from the electronic health record system and de-identifying any HIPAA data elements, the dual annotation of ADEs by clinicians takes place. This corpus will then be sent to IBM to train the IBM Annotator for Clinical Data on this corpus. Annotating a random set of notes is something that has low prevalence will result in a biased or imbalanced data set. And so ideally, we want to have a balanced data set that is split between 50-50 for cases and controls. So this requires us to upsample nodes that are more likely to have ADEs in them. And to curate this data set, we conducted a sampling study. So we utilized an iterative process to investigate the prevalence of ADEs within our outpatient clinical notes. This consisted of several steps, determining the prevalence of encounters with relevant billing codes by causality category, and then determining the prevalence of those clinical notes associated with each of those encounters within each of those causality categories that describe an ADE. And then creating a sampling plan for the corpus curation purposes that is both balanced in terms of cases and controls and diverse. So it includes both rare and common ADEs through upsampling or downsampling of the causality categories or specific ICD-10 codes of interest. We looked at the prevalence of billing codes within the causality categories used in prior studies. And we looked at ambulatory encounters between October 2018 and December of 2019, using those 608 codes from the whole and expanded to include the lower granularity terms as well. and then we captured the distribution by causality category. And so our goal here is that to capture this distribution, and we hypothesized that each of the causality categories would have a different distribution. So we have about 1.7 million outpatient encounters annually at our organization, and we identified 656,000 encounters within this 1.25 years that were associated with the billing codes of interest. And we categorize those as into the causality categories by ICD-10 code. And so most of these are in that ADE possible, and about 62% of those are in that E category, which corresponds to about 292 possible ICD-10 codes. Another 18% were from the ADE likely category D, and that's about 20% of the corpus. And so this gives us a starting point to investigate each category further. We have another project in the MTerms lab focused specifically on rare severe cutaneous adverse reactions, or SCAR. These SCAR ADEs cover 4 disease diagnoses, so SJS, TENS, AJAP, and DRESS. The latter we found was not covered in Hole et al., and we found that these were not very prevalent in our sample, which is what we expected to find. So once we have these distributions by prevalence categories, we looked inside to the clinical notes and looked at a sample from each of those categories, about 20 to 30 each, to see how likely it is that those encounters have a ADE within the notes. And so we looked at 218 notes sampled from 1 week worth of encounters as part of this classification task. So we classified them as yes, no, or maybe ADEs. And so the percentage varied by what category we looked at. The A1s were between 67 and 90%. B1s range from 80 to 85%. The Cs were in that 40 to 70% range, and the Ds and Es were within like the 4 to 8% range. And so we have sort of this variability associated with these billing codes that corresponds to this causality category. We later reclassified the 19 maybes as we looked at the defining our annotation scheme. So there are a lot of other encounters that we also need to sample. And so ADEs are potentially documented in visits that are associated with diagnoses that weren't previously studied. And so we need to do some more investigation on this. We anticipate that the ADEs will be relatively low prevalent in this population, as they don't have a billing code associated with them. And we can exclude encounters if a patient does not have a medication on their structured medication list, potentially. And we could use natural language processing to screen for the notes for encounters to identify medications and adverse reactions in order to find a subset that likely contain ADEs. Our goal in doing this is to be able to upsample these particular notes so that they can actually get into our training set. And MTerms has a linguistics focused tool called MTerms, which we've previously validated on the task of medication extraction and adverse reactions extraction. So how much do I need to annotate anyways? Well, that depends on your sample size calculations. For example, there are sampling size calculations available for calculating the sample size need for kappa, as well as other statistics that we need to calculate. And so we want to be sure that we calculate these so we're annotating enough data that our system has statistical power, but not too much that we're wasting time and money. I won't go into details of these calculations here, but it's something to be aware of. And so for the ADE corpus in particular, we plan to dual annotate a corpus of about 3,000 to 5,000 notes using multiple annotators. Our proposed sampling plan has about 1,400 ADEs, and we're looking at a balanced ratio of about 50% ADEs to not ADEs. And so we'll refine our targets as we annotate the corpus. For now, let's talk about the annotation process by going through an example of how one might get started doing annotation. So here's a snippet from a clinical note. And really the first task is to highlight everything that a clinician would find important or interesting as it relates to adverse drug events within this clinical note. In this task, information is hidden in the unstructured clinical note, and so domain experts, in this case clinicians, help to identify what's relevant. So there are a couple drugs in here, Ritalin and phthalimide. There's an adverse reaction, a seizure, and there's another drug, phenytoin, and there's also a discontinuation or change in medication status as well. So in the first pass, different annotators may have highlighted totally different concepts, which is expected. We repeat this task on another 10 to 20 notes in order to gather enough data to begin formulating a codebook or annotation schema. In this annotation schema, we add in specific definitions for each concept, including inclusion, exclusion criteria, define rules and windows for spans, and which refer to how long of text to extract. And we define the span for each concept to include everything that makes it a standalone concept. So once this annotation schema is created, we re-annotate the first set of notes to see if anything changes that is due to the new definitions in the codebook. And so this will help to sanity check that the annotation schema or codebook is consistent with the initial annotation in the areas that make sense. So now that we have the annotation schema, our next step would be to bring in a second annotator and train them on the initial set of notes, compare results, update the annotation schema as necessary. Once this initial training is complete, it's time to test the annotation schema and compare our annotations against theirs on a small batch, say 10 to 20 notes. That depends on the size and time it takes to go through a set of clinical notes. Most likely, we won't have 100% agreement after this step, which is why it's important to pause and compare notes intermittently and to update the codebook so that all annotators are using the same criteria and are interpreting those criteria in the same way. To make this comparison easier, we build the codebook into and conduct annotations in a specialized annotation tool. Crowdsourcing annotations from something like Amazon Turk is another option for the annotation task when the clinical data is de-identified, as this approach has been shown to produce reliable results, though participants likely don't have the clinical expertise necessary to produce valid results if the task requires substantial clinical knowledge, such as our adverse drug event example. However, more annotators don't necessarily improve the quality of annotations, just the quantity and speed at which they can be found. Once we have a validated annotation schema and trained annotators, it's time to annotate a lot of documents. During each batch of documents, 20 to 100 say, the codebook should remain set, and each annotator annotates their own against the codebook. It's extremely important that assessments are conducted independently, and the annotators do not discuss the annotations with other fellow annotators during this coding batch, so that the definitions of the codebook, which are considered the gold standard, are not contaminated. And contamination at this step is failure, and all of that work will need to be thrown out. Outliers with influence may indicate an error or perhaps another population that hasn't been previously considered. And so then you can update the codebook after that batch and re-annotate what you need to with those new definitions. So let's talk about how to assess Integrator reliability for a moment, which is how you assess whether or not you're producing reproducible annotations in the same way that other people with similar expertise would. Kappa is basically the standard formula for assessing Integrator reliability between annotators. Cohen's kappa is the traditional formulation, which uses 2 raters. However, I prefer Fleisch's kappa, which is just a generalization of Cohen's kappa, but allows for more than 2 raters. In this case, we're really looking for a kappa greater than 80% for our annotation tasks, and that would indicate a strong agreement. With all this in mind, this is the current proposed annotation schema, including entities, relationships between those entities, and modifiers. It was developed based on previous work on ADE identification using annotation schemas from the N2C2 challenges and MADE 1.0 challenge. It focuses on using only a subset of the aspects of the drug signature in order to capture only those aspects that would be clinically useful to identify ADEs, whereas the N2C2 challenge focused also on that medication drug signature extraction task. So we have a few lessons learned already. So not everything that has a relevant billing code necessarily corresponds to an ADE. So there are particular clinical workflows, such as ordering skin tests, that may require an ADE-related ICD-10 code for billing purposes, but the results of these skin tests aren't yet known. And so this is an area where we would want to exclude this from being counted as an ADE because we don't know yet what those results are. The MTerms lab is focused on the application of health information technology, such as natural language processing, to clinical practice. For example, the NLP systems created in the MTerms lab have been integrated into our organization's electronic health record systems for tasks such as medication reconciliation. The NLP tools developed in the MTerms lab range from linguistics-focused tools such as regular expressions and ontology-based tools to statistics-focused tools utilizing machine learning, topic modeling, and deep learning technologies. We have a wide range of different applications that we've been involved with, and we're certainly open to collaborations with other academic institutions and industry partners as well. So I would like to thank my collaborators at Mass General Brigham and IBM Watson Health. Here are some references that may be of interest to you. Thank you for your time and attention.